how many of you have published abstracts or presented a conference? Most of you, right? How often your abstracts, in your CV, tell me the ratio of abstract to publication? How is that panning out? So mostly end up as abstract, right? So this is a safe place. Let's talk about your experiences, okay? Why your abstract could not get into or get converted into a manuscript? What happened? Time, okay? Do you know what? By the way, that is the most common variable that people talk about when you ask them why you did not finish something or did not do the research. Okay, time, I'll answer that. What else? What do you mean by cost? Oh, publication cost. So here it is. I'll confess here, I don't think I've ever paid 1 penny to publish. I'm not trying to boast something, okay, but done like maybe 300, 400 papers, I have not paid 1 penny. So I think we get exhausted very quickly, and this is a new culture right now. Like, you know, some of them are genuine good journals where you will get a fair review that you will learn something from the process and they give you good feedback. But whatever I've seen with some resident or fellows where you pay, right, this open access so-called new culture, because mostly the journals are online. They don't even have a physical copy, right? And I think they're, first of all, charging crazy money for nothing. And the peer review is so crap to the point that I've seen comments, English no good. And I'm thinking, who writes like that? Okay. I mean, say even if you're going to comment on the English language, this is how you're commenting. I mean, come on, man. Right? So, and I can show you. I have story after story to tell you. Okay.
So I think if you are coming from maybe a smaller hospital, not university based, with some of the case hospitals, you don't have the financial support, and you don't have access to, like here, for example, I know we have British Medical Journal, you can publish for free, but that's not the case at those smaller hospitals. You have to pay your own for Curious.
Yes.
And I think that's
so Curious is another curious story. Okay. So what I'm trying to tell you, look, guys, I'm not trying to demean any one of those, but in which club we will go is up to us. No faculty or anyone can force you to tell you, right, that which club you want to publish. What I'm saying is this, in my experience, I'll give you story after story of real world examples. Hopefully that will inspire you to think a little bit bigger. And even if you fall, you will fall in a very good place. Versus if you're thinking from Curious, there is nowhere to go. Because Curious is, come on, it's a pay to play most of the cases I've seen. Reviews are not good, peer reviews. The process to look like, because what is the purpose of peer review, right? I don't take it personally when I get a review back, right? Because if it's a good peer review, it teaches you, it improves your article. Constructive feedback gives you a specific thing. Versus English no good, I mean, I don't know what to do with it, okay? You know, I don't like something. That's not a feedback, right? So, and another thing, if you see incompetent reviewer, they should not tell you that do this. Who are you telling me what to do? Whatever I've done, judge on that, whether it's adequate, inadequate, how it could be modified. That's the, like, you know, quality of a good peer review, which will happen if you start wherever, you know, little bit higher journal. I'm not saying high impact factor always publish good things. No, there is no correlation, but at least there is a higher probability of getting a fair review. Okay, so that's what I see. And remind me, I'll tell you about the resources and costs. So time, you know, my friend, it's like a relative concept. I'll tell you why. Because time it's a dual-edged sword. So it's taking you a lot of time because maybe indeed it is very labor intensive what you're trying to do. So then I will also blame myself because maybe we did not brainstorm very well to think about the feasibility and logistics, what it will take to do it before we got into something. So we made a wrong choice. It could be that, or it could be simply that we are working too hard and not smart. Right? Because if you don't know what it will take me to finish, the most common refrain, you must have heard it, when I talk to some friends and they come in support of all of you, right? They say, oh, they are doing a lot of clinical work. That's why they don't have the time to do research. But unfortunately, my friends, you know, I have very biased sample with me. All my collaborators are clinicians, okay? But you will see one pattern if you put in the AI or review my CV, that most of my collaborators are outside USF and 99% are clinicians, full-time, okay? But what happens is a culture where I don't know, you start enjoying. First, it looks very daunting when something you do, but once you see the results and you see the fun in answering question one by one, it becomes kind of joyful experience. So I'll give you one quick story before I go through the slides. Slides I can send it to you, you can read on your own. So here was, I will not name the person, but that person was a fourth year math student here. That student, right, at 5 o'clock, I don't know from where, I don't remember all the name, but then he came and introduced himself again. I remember the faces. Okay. I see some faces from med school here as well. So, I don't remember all the names, right? So he walks in and says, Dr. Kumar, do you have like 10 minutes? I said, sure. What is it? He said, I'm going to send you an email just now. Can you look into it? Because it was a rejection from a journal. And, there were some comments. It's, can you look into it? I don't get it. And it was something about staff because it's wrong. They should have done this and that. I read that quickly. I said, you should be happy they rejected it. He said, what do you mean? I said, who does this trashy work? Everything is wrong here, man, for the following reasons. That's what I told him. And I will tell you his name even. You can Google him now after I finish the story. And he said, oh, really? He didn't understand. He said, I don't understand what you're telling me, but I get it, what you're telling me. Okay. But can you help me fix this? I said, I can help you fix this, but it's not a fix. You have to redo it. It was a simple survey about how often medical students have mentors or find mentorship. Okay, that was the whole simple. I said, we cannot go and fix the survey, but whatever data you have, you are analyzing it wrong. Okay, in terms of, right? But he agreed to that and he did work with me and it got published. Not only got published, but also there was a podcast made for that particular paper, right, on the mentorship. So in my view, looks like he can confirm whatever he thought, but he tasted blood. Okay. He started enjoying the process. And for whatever reason, he wanted to match into very competitive program. He did not match and he matched into some community hospital. He was very depressed, right? But he knew the only way to get out of this is to build his CV. Because thankfully, still people respect that research. If then they see something, even if they don't understand, they think that is really something good that if something you were able to accomplish. Okay, that's a common theme what I've seen as well. And then what he did was because again, coming back to the time and logistics aspect of it, when you are something, you cannot spend so much time manually extracting data. But now you have some services which can extract data for you if it's in an extractable format. So he decided, okay, because we did not have connection with that hospital, he asked for help, right? So he thought of doing systematic reviews and meta-analysis. But every day before he finished the clinic or after he finished the clinic, he had at least one question from whatever patients he saw. One question, which got converted into a PICO question. You must have heard about that. Very simple. It's not rocket science. And then we worked through it, and you can Google it again. In 1 year, he published at least 5 systematic reviews and different studies. And all of a sudden, in 2 years, 3 years, when he finished it, first year he thought he'll be competitive. But unfortunately, still there are a lot of perceptions for fellowship. Instead of evidence objective, we rely on that's a good program. How that program is good, nobody knows. Okay. But we all rate those programs highly or lowly, whatever. I have not found objective evidence about that, but there are reputations. Okay. So he wanted to go into cardiology. He did not match the first cycle. And most common theme that I heard from program directors, whom I knew I talked, right, was the word being used, pedigree. Okay. That he came from a community program, perceptions again, right? And then what he did was he still kept publishing, right? Good quality stuff. No one could critique the work, right? But pedigree. So he got a gap fellowship, 6 months, 1 year, sorry, in University of Alabama, Birmingham. Okay. He got there, but he kept producing. And next year, all of a sudden, the candidate was very desirable to the point that they were competing to have him there. Okay. And so long story short, the guy is still remote. He's in Miami. But we still talk once in a month and we have a question and remotely we collaborate and we still keep publishing together. So the point that I'm trying to make is distance, whether time, Research is a teamwork. If you're trying to do everything yourself, you have bad collaborators. So, but if you think from, let's say you are in the clinical practice and you have a question or uncertainty about whatever you saw that day, what is the next step? Is to answer the question. Never ask a colleague. That is the worst documented in evidence perspective, that somebody telling you what to do versus you going and trying to confirm yourself from the evidence, I think is the most optimal approach, right? Instead of going whatever, because there's no correlation between those two of the reliability of the answer, right? You can do that. While you do that, there are two benefits. First, of course, if you find the answer, you empower yourself, you learned. If you did not find an answer, then we can brainstorm what is the most feasible research design that we can do for that question, given the time, effort, money we have, right? IRB will approve any protocol, okay? That protocol quality does not guarantee you anything. But if you follow the checklist approach to writing a protocol, your half paper is done because you're writing everything unto the methods, right? And it's very clear. We can, if you have written something, we can brainstorm, debate, discuss, and say exactly. Otherwise, when we are talking simply, I don't know what I'm talking about, you know what you're talking about. We can argue forever and you will forget, I'll forget. But that's how it happens in writing, right? So I thought, let me talk about the process and show you the results. And if you have specific ideas, plans, question, we can have more of a Q&A session versus I keep talking to you about t-test and non-parametric and parametric methods. I can keep throwing jargon after jargon. I don't know how helpful that will be. Because if the question is set up right, if the exposure is set up right, analysis will be, and data collection is correct, okay, in terms of the way, analyzable format, the analysis will take 10 minutes. Because most of the time is spent cleaning the data because people collect in text, not numeric format, and so on and so forth. That's what kills time. And that's where the time comes into play. And you will be disappointed, your collaborators will be disappointed, and then it's like a downhill battle, right? So here it is.
I think you have to click the trackpad.
Oh,
No, the trackpad, yeah.
oh, this here. Oh, so can I minimize this simply? No? Okay, let me do like this. Give me 1 second. It should work now, no? Yes? Yeah. Okay, here it is. So I'm just going to give you briefly about whatever the study designs most commonly that in medicine we use, okay? And why it is important to match the study design, that for what questions you can do something, right? And then we will talk about this and give you some examples, okay, very quickly. So as a clinician, you should know by heart, right, what are the most common study designs that you can do? Keep this in mind, this diagram, that's always helpful in thought process. At the end of the day, you decide, if I want to do research and I have a question first, right? What I'm trying to do, am I trying to describe or quantify? If you're trying to describe, surveys are there, qualitative research is there. Okay? So this takes a lot of time. Generally takes a lot of time. And also knowingly, again, follow the principle of clinical practice. Anytime if you have to ask patient about an outcome, that's the worst form of data collection versus quantitative measures. So most likely we'll end up on this side, analytics side, right? As I said before, in analytic, you have intervention, that you are in charge of who gets what drug, but most likely will fall under this side, right? That things are happening, all you're trying to do is quantify it, and these are the study designs that you should be familiar with. What it looks like, and again, if applicable, if all the designs are applicable, then only we can talk about the hierarchy. But a lot of questions, especially question domain, not every single study design is even applicable for those questions. So when I talk about the questions, right, we'll come to that, but let's look at briefly the designs. Like I said before, sampling, exposure or intervention, counting, common theme. Simply here, we are randomly assigning. So anyone can briefly tell me what is so great about randomization? Why we swear by that they are the best study design? Why?
Yeah.
Oh, of course, I agree with you. Selection by how?
Because, for example, if you're trying to compare treatment, sometimes you will choose the less sick patients for the treatment arm. So it shows.
So you're telling me we are unfair? We bias things.
You do?
Come on,
Yes.
man.
We
We are
do.
corrupt?
Subconsciously.
Subconsciously, okay. So let's say, I'm doing the study. I will not pick and choose. Got it. Got that. Sorry. I don't know which screen. You can minimize that screen, maybe. Yeah, oh, here it is. This, okay. All right. So let's say, right, that he's doing a study. He contracts me to create the group, and I do male to male, female to female, and I create exactly similar groups. Will that be a problem? Why? That's confounding. Somebody said confounding?
Yes.
Oh, confounding, sorry. Confounding, right? So sure, but I'm saying if I know the confounders, why can't I balance it? So let's say age. Of course, we know as we age, right, likelihood of falling sick is higher compared with when you were young, right? That's a confounder. But what if I match 1-to-1 completely? 20 years old, 20 years old, male to male, female to female. Can I do that?
Even the act of actively doing that will itself cause.
Why? Come on. So what I'm trying to see, I'm trying to demystify the jargon, right? In simple terms. Like, let's talk in simple terms, guys. That's the magic word, okay? What he said before also, we didn't catch it, but he said, we can always knowingly account for any factors. Human beings can always do, but unknowns are unknowns. And except randomization, there is no other way to balance the unknown confounder, because people have done this simulation even, where they matched everything. And after that post hoc, they came up with few factors to see what is the distribution across the two groups. And only when you randomize, you will see that those unknown confounders, which are measured post hoc, turned out to be equally balanced in both the groups. So that's why we kind of swear by randomized trial for intervention questions, not for all questions, only interventions, that they are considered the most unbiased. Here.
Click it again.
Yeah.
Click on it. Yeah.
No, it's in this window I see here. It's came here, right? Close this one. USF needs to buy a new computer here. Should be okay. Yeah. Yeah. All right. Yes. So here it is. What I was talking about, cohort studies, right? That's one of the major issues in observational, that you find people simply exposed and exposed, but counting is same. And one thing is common in randomized, and this one also non-randomized, that you can measure multiple times over a period of time, right? Then comes the cross-sectional. Here you go. You cannot, people have take the drug and not take the drug at the same time. It means this study design cannot be done for intervention questions, right? There is no way you can do it. And in this is unique. You can measure only once. You can't even measure twice in this one. I'll give you an example shortly. And then there is a case control study design. So in that, you see the sampling starts with cases and controls, or in terms of outcome. So instead of following and seeing who's going to die and who's going to live, you start by finding people who have already died. So this is a retrospective study design. Things have already happened. You're trying to collect the data, but you start with the outcome. Okay, sampling starts with the outcome, and then you go and look for exposures. What might be the reason for the death or no death, right? In this case. Then there is most common, what, I don't know, I hate the term, but people use it very commonly, chart review. There is no such study design. That's a means to simply collect data, okay? So most commonly I've seen people do this. This is a retrospective cohort study. So imagine the example of smoking and death. So first example, case control, you start with people who are dead and alive and look in both the groups, how many people were smokers versus non-smokers. But in this case, sampling will start with known status of smokers and no smokers, and you find how many dead or alive. Hopefully you will have the dates to see that death happened afterwards, not before, right? To make sure you are not messing it up. But this is one of the common retrospective cohort studies that get used in clinical research during the training, okay? And just showing you the difference between the two, case control. Both are retrospective study designs, but one, case control, will start with, outcomes and follow the exposure. But this one, retrospective cohort, starts with exposure, follows the outcome. Okay, remember that. All right. So When you hear the term quality improvement, you'll hear very commonly people come up with something new, policy or etc., and try to see. It's nothing but it's a pre-post study design in most cases. The appropriate study design for quality improvement will be a ideally highest level of evidence will be a cluster randomized trial and where you don't randomize patients. But imagine there are 10 hospitals, right? And you're going to introduce a new measure, right? Which is supposed to be enhancing safety, medical errors, adherence to the drug, whatever the outcome might be. You randomly assign those interventions, in terms of policy to 5 hospitals and 5 FAR network. That will be ideal. But you can't do that. You don't have the time, money, resources to do that. So most commonly you will see pre-post. So you take retrospective data, pre-intervention, whatever the outcomes were, and post. But as you know, there are so many unknown things going on that the validity of those findings is, suspect to say the least or biased in this. But the principles of any study design applies even to quality improvement. You can do a good job with low risk of bias versus at high risk of bias. But knowing those biases is very important because even if you cannot address something, at least you can have in the discussion that most likely our findings are impacted with the following biases that we think might have creeped into the process, right? That's it. So looks like all of you have done some research for sure, right? How do you get the question? Where did you get the question from for your research?
It'd be a real clinical situation that you encountered and you didn't know what to do.
Wonderful. So I tell people all the time, if you see patients all day and you do not have anywhere some uncertainty that I wish I knew more to do something, quit the job, man. You're doing something wrong. Mm-hmm. Why? One thing is very underappreciated in medicine is the uncertainty. Being uncertain is a smart thing. It's not a bad thing. But simply being uncertain and not addressing that uncertainty is a bad thing. If you are uncertain, do something about it. And that's where I was saying, so great answer. And that's the only answer, actually. Whenever you see something, you should have questions. There is no way we can know every single aspect of that care or that encounter or whatever it might be. There's always some doubt that I wish I knew more. And that's where, ideally in clinical setting, you should get the question. But once you get the question, right, make sure to convert that into the PICO format. I call it arm, leg, and head of a question, otherwise a blurb. When you ask the question, what is influenza? Okay, that's a background question. Doesn't require research. You read a textbook or just Google or AI will tell you that. Okay. Now, right? So, but when we talk about research, right, you have to have some specificity in terms of PI. I'm also talking about T, what type of question you're asking. And mostly you deal with 4 question domains in medicine: treatment or intervention, diagnostic accuracy of something, prognosis, or side effects. That's what we commonly deal with, right, in clinical medicine. So here it is. And remember this. So that's why I was showing you the study designs. When you talk about diagnostic accuracy of something, cross-sectional analytic study design will be considered the most unbiased study design, not randomized controlled trial. Okay. When we talk about prognosis, try assigning randomly gender to somebody. Can you do it? Of course not, right? But we have memorized, try assigning whatever age to somebody. You can't do it. So you have to have a prospective cohort study for prognostic question. For treatment only, it's randomized controlled trial. And I've not put here, but there is another domain of question, which we call it diagnostic utility. There is a big difference between accuracy and utility. So accuracy means, okay, this test works in terms of classifying people correctly, diseased and non-diseased, or stage, or whatever that scenario might be. But utility is about that both diagnostic modalities are accurate. However, we don't know that if you use this modality versus this modality in the long term, what outcomes will change. So most common example you will hear about, let's think about this, right? If we use a simply symptoms-based diagnosing, let's say COVID, versus a PCR-based test, or 2 PCRs, different ones maybe, right? Using one or the other might be associated with long-term after diagnosis, whatever you do, what outcomes happen that you can attribute to how you diagnose them. So another example, which will make more sense, for breast cancer, screening mammograms versus self-breast exam. What you do first will have long-term consequences in terms of how quickly you find false positive, false negative. As a result, it will trigger some biopsies, false positive, etc. And ultimately early treatment or no treatment, whatever that might be, and where it leads, that's the diagnostic utility question. For that, you can do a randomized control trial, but not for accuracy, okay? Then, and also, sorry, remember this, anytime a synthesis of similar studies for similar problems or similar questions will be considered superior to any single study. So always a synthesis is better than a single study, all right? So question is done. What do we do next? Once you have the question, as you said, first go and do a PubMed search. What is the answer to your question? If you find something already, what does it tell you? If nothing else, forget about research. You empowered yourself. You learned about it. That was the right answer. Got it. But if you want to do more research, you saw 4 studies. Read all 4 of them. I'm pretty sure there will be some differences between those 4 studies in terms of whatever they found. If nothing else, the magnitude of effect will be different between those 4 studies. One will say it cut the risk of something by 20%, one says 40%, one says 30%. What's the true answer? Right? So you can very quickly, without IRB approval, you can do a systematic review if there are similar studies. If somebody has done already, let's say you find 4 systematic reviews. I'm throwing all the options there. I don't know if you know, do you know that there is a design called overview of systematic reviews? It's a systematic review of systematic reviews. Here you go. And I'm telling you, and whatever I'm going to tell you, I can show you an example. Yeah, exactly. Real meta. Yeah. So you do that, right? So that's the highest you can produce, because I'll show you example. We did in cardiology one, where overview of systematic reviews, and we found that 3 of them were crappiest systematic review ever, because there is a checklist to evaluate the quality of systematic review. The same way, something is called randomized control trial. You cannot think that, oh, wow, it's randomized trial. You can do a trashy job with randomized trial. You can do a trashy job with retrospective cohort study, and you can do a good job with any study design. And there are specific markers to evaluate that. It is not simply that I am telling you, but the field has studied that to document it. And you contributed to decision-making by calling it out. Just because it's published means nothing. Done by Harvard, I said, even God comes ask for an ID. Okay, who cares about Harvard? So you should have those objective metrics to evaluate research. So when you do literature review for your question, it has multiple benefits in my view. The most important, like I said, opportunities to do something, add to whatever already is known, depending on whatever you find. And when you know something is crap, based on objective metrics, you can do your own retrospective cohort study, or you can decide to do a critical appraisal of those and publish that as well. And I'll show you more examples of that. And that's why, if nothing else, if you want to do your research, you can, any introduction section. For me, the most difficult section to write in a paper is introduction. How do I convince people that why this research is important? That's the most difficult. And to convince that, you have to quantify what is known or not known about the study, about this question, sorry. And the moment you say that what is not known, your question objective becomes very simple, straightforward. So to do that, you need to do a lit review for any purposes, right? So don't leave the question hanging, address it. It has multiple benefits, okay? So that's why I'm giving the algorithmic approach, that it's never a loss when you do a lit review, okay? All right. Same thing, bottom line, never start a research without summarizing what is known and not known about that particular question. Otherwise, that is called also Me Too research. And that also becomes very problematic to publish, because there are already 10 papers on that. Your 11th paper is not going to add much. So find the niche of what you're adding. And that's where I was saying that brainstorming is always very important. Discuss with people. You will always find some opportunity to do smart research, not hard research. Okay. So If nothing else, after brainstorming, please develop a good protocol. And to develop a protocol, there are checklists. Don't reinvent the wheel. Don't Protocol or writing a scientific paper is not looking at your ability to master the literature or English language. It should be simple, specific, to the point, right? And very important to articulate. Every day in the shower or the bathroom, I get so many ideas, but 99% never go anywhere because you did not write it down. If you don't write it, all ideas are good until proven wrong, right? But means nothing, right? So write it. Okay. Why? I go and call, let's say, a colleague. Hey, I want to do this study. And the guy said, okay, what is it about? I said, today I gave an idea, right? To Sadaf, I was talking about, hey, do you know what? I want to take like 30 days of all the major 5 news outlets, take their reporting on any scientific term, and then we can quantify it, right? Whether it's like objective or simply a narrative they were giving, no details, nothing, right? And show that how it needs improvement, right? Something like that. If I don't write a protocol, do you think any one of you is going to pursue that? It's going to die down somewhere. We all get busy with our lives. Number 2, but if I write a protocol about that, how I'm going to do it, what I'm going to do, and send it to her, she will be kind of feeling a little bit guilty that, oh my God, he sent me a written protocol. Let me put something at least, before I give it back to. And I can also be a little bit harsher on her. Hey, I sent you a protocol 5 days. You haven't said anything. Do you want to be on this? But you see how that you can hold people accountable when you have something in writing versus just talking, right? So you have that a great opportunity for constructive feedback. I tell people, when they call me, I like your protocol. I say, come on, man, give me a break. That's not a feedback. How can it be I wrote a perfect protocol? Don't try to flatter me. Okay. I mean, if you say you have nothing to say, either really I'm a genius, which is, I don't believe that. Okay. Or you have nothing to say. So I'm collaborating with the wrong person. So everything, whenever I send, it says, awesome, good job. That's not feedback. Colleagues should keep you honest, right? So find those collaborators who will give you that feedback to make your product better. Thumbs up is not a feedback. Okay. So I have one who always writes, awesome. Okay. So that's where I think specificity comes when you write it up and you summarize that, right? Whatever the topic it might be. Okay. Here is the website for the group that I lead. If you Google simply, don't have to remember the website, but if you Google RMBC USF, you will get like a submitted ticket. So we take pride in responding within 24 hours. Normally you will hear is set the expectation, very clear. You will get an email from a real human being. We don't have any bots. Okay. That we will get back to you within 24 hours. They will ask you for a meeting, because they will not commit to anything until they meet with you and brainstorm those issues to make sure everything is clear. Then only we commit to something. Otherwise, they will give you very honest feedback in terms of, look, I don't think so, it's still ready, but do you have a protocol or how to write a protocol? Depending on wherever you are in your research journey, you will get, and do you know what, you see what services we offer, all these things? Most common requests we get? Brainstorming and studying feasibility. And here it is. I take pride in that because leading that, I have awesome people, very knowledgeable, down to earth people will give you very good feedback. And also we are 100% funded through grant money, although we have state money, but we barely use the resources. All through grants, contracts, something. So I take pride in that. And we don't send one ad. We never advertise knowingly, because we get too much noise and we say, oh my God, nothing is happening. People simply, talk is cheap, told you before, nothing moves, right? Because ultimate win is what? If you and I are collaborating, if nothing else, we should get a publication out of it, at least to inform the world what we did, right? So that's the resources there. Here is a summary of the process I tried to outline. Start with specific question, which comes from your clinical experience, right? Of what our patients are. Do quick search, PubMed, empower yourself. At least you will learn how to find answers quickly. There is, I don't know how many of you use in PubMed, there is a feature called clinical queries, which already has the inbuilt filter to limiting your search by matching the study design to the research question. So they have a menu there. where you can pick whether your question is treatment, harms, etiology, prognosis, diagnostic accuracy. Okay, so start with that. Summarize knowns and unknowns, because that will help you make an informed choice about your study design, what kind of research you want to do. Write it up. Like I said, IRB is okay, but at least you will get feedback from your team members, right? In writing. If needed approval, you can proceed, right? Then comes data collection. We have a team of informatics people. Depending on what you have, we can extract data from the electronic medical records if it's in quantifiable format, not free text. So anything could be extracted. So you don't have to sit in front of a computer and one by one extract MRN numbers and whatever. If you can even talk to them about feasibility. So for example, you want to study something unique, you tell them the ICD code, they will tell you how many such patients exist in USF TGA system. Okay, so that you know you're not going down a rabbit hole where you did all the work, approval, but it's not feasible anymore, right? So do the good homework. And of course, we can do this in one day. Data analysis is not complex. Okay, that's why I didn't want to bore you with stats and all those stuff. Okay, so, and then comes the writing. For writing, for every single study design, there is a checklist. Follow the checklist to outline whatever you're reporting. Don't try to reinvent the wheel, right? There are plenty, right? So here it is. And, before you finalize it for peer review. So I see a very straight cookie cutter approach to the process. Okay, it's not very complex. And that's why I said time is a relative component, because have some good collaboration. This was 2005. I was a very brand new faculty at Moffitt. Okay. And I had worked as a research associate with one of my mentors, right? And you can Google that guy up. This guy comes to my office. He's a new faculty also at Moffitt, at bone marrow transplant department at that time. And he said, hey, I read your paper, that one, it was a systematic review I had published in Lancet Oncology that time. This is 2005, okay? And he said, how do you do that? So I said, have a seat, man. And I gave him a 5-minute spiel, the process, how to design. He said, that makes sense for collecting evidence, because otherwise review articles are just opinion pieces. I said, yeah, that's true. And he said, I have a question. Can you help me do one? Okay, and you can Google him. His name is Mohammad Kharfan Dabaja. He's the chief of the BMD program right now at Mayo Clinic. And imagine I did something right, we are still friends, okay? So that guy, right, you can Google both of us, our PubMed search, right? Since 2005 until now, we have published together at least 100 papers. So you see, distance is not a problem. You can still work, but if you have to know what exactly we are trying to work on. If the request is specific in this world, we are so much connected. Instead of sending thumbs up on Facebook, we can do something meaningful, right? To do that. That's how we use it. So that's why I said time, is a relative component. If we have very efficient people around you, you can always accomplish your goals. So find people who can do this. This is very important. What you remember right now, if you cannot figure it out, you will not remember 10 days later. I will not remember. And once we talked, I don't remember next day even, because we have so many conversations with so many people, right? You forget, right? So timely and specific communication. And that's what brings to availability. When you have a team, make sure they're available. Otherwise, you're hanging out with wrong people, guys. And there are plenty of them, unfortunately. Okay. Protocol. That's why you need, what's your request? What do you want? Right? Be specific with those requests. And that's where I'm saying team members, and always have a self-imposed deadline. Otherwise, there is always something to do. It never gets done. Okay. That's what I've seen in my example. So does it work? All the things that I told you? I think it works, depending on the metrics you look at it, right? I've not updated it, but we do from primary randomized trial. We are the methodology team for HBOT study that is going on, right? And so many other trials, right? We do clinical practice guidelines. We do systematic review. Of course, that you have to do as part of the clinical practice guideline. We do big data, all these buzzwords. We do it. Simply, we don't advertise, unfortunately. Okay, but this is the reason. So it works. You will find collaborators, productivity, and it has to help everybody. You know what? Two people are collaborating. It's good that we are volunteering time. But that volunteering time, at least both parties should feel good about that they accomplished something. If it does not go somewhere, both parties will be disappointed. And that is one of the hindrances to future collaborations. Success breeds success, right? If you publish together, you will remember that person, you will go again and again and again. And last denominator, right? If nothing else, even if you're not going to be in academic medicine, where publication might not be important, you will still be a consumer of research. You better be, to keep improving yourself for lifelong learning, right? You have to find. There is no some great person which has all the answers or who has all the, there's no such thing, okay? Information is democratized, right? All you have to do is empower yourself, right? So here are some examples. We did a similar program with Division of GI, but we made mandatory that every fellow with the faculty has to meet for brainstorming before they even start a research project. Because I believe this, that if a fellow is not completing something successfully, somewhere we are at fault. Because we did not provide something, we did not provide enough brainstorming opportunity or whatever it might be needed, right? So we made that, we answered question or diagnostic utility, right? Here it is, we did I forgot to tell you, there is another design called systematic review, not meta-analysis, but network meta-analysis, where in absence of head-to-head randomized trial, let's say, because what happens in industry, one company has drug A, other company has drug B. To keep their market intact, they never do a trial of A versus B. They always do A versus standard, B versus standard. So network meta-analysis helps you compare one against each other. And I'm very proud in this case, there are some here, the company which came up with the device got bankrupted, but they filed a complaint against us that we are doing something wrong. I take it as a pride badge of honor. Okay, we upset them, but it was their data, so not mine. Okay, so see, I'm saying what I'm trying to say is, guys, maybe you're not understanding, but I have fun every day. Okay, doing the work because I truly enjoy to address how do you know what you know. And that's why I was telling that analogy. Sorry if anybody is religious too much, that if God comes, ask for ID, because how do you got the wrong God, maybe? Okay, so that's what it is. There is no eminence, focus on evidence, right? That's the key message. All right, here is most recent one, something, right? Critical, remember, we found multiple guidelines. And I told the fellow, listen, these are shitty guidelines. They're done wrongly. She said, Dr. Kumar, what do we do about it? She was one of our students before. Now she's attending, Shreya. Okay. Yeah. Okay. I said, hey, do you know there is a design called critical appraisal of guidelines? There is an agree to checklist to look at the quality of the guidelines. Just because something says CPG does not mean they are good. Okay. So we did a quality of that. And look at that. The quality is moderate at best. There's scope for improvement. Didn't pay 1 penny to publish this. Okay, just to add to that. Okay, what else? Oh, this is one of the recent one that we did with St. Jude Global. We are the official methodology team for St. Jude Global Pediatrics. So we did this methodology experts we are for them to develop this clinical practice guideline. And hey, you can critique this guideline. Okay, in terms of quality as well. So bottom line, I'm trying to show you that teamwork is so important. You cannot do it alone, but you set up. And once you have the knowledge and the skills to set up your research project, you know what kind of help you need, and you can ask for specific help. And that's why I'm saying, if you have a systematic approach, because if you know you have 10 steps, you know that at which step for this one you are stuck. And you know for that number 5 or number 6, whom to ask for that help, who might be good at, not based on the claims, but go and Google their CVs first, whether they have done it or not. And they are more likely to help you in an appropriate way because they have a track record of doing something. So that's what I'm saying. If you have a teamwork and systematic approach, increased output. That's all I have. Yes.